All right, so today's webinar is presented by Dr. Siobhan Harrigal, a board-certified radiologist specializing in breast imaging. In her work at St. Mary's Regional Medical Center, she detects and diagnoses breast cancer by reading mammograms, breast ultrasounds, breast MRIs, and performing minimally invasive non-surgical breast biopsies. She also sees patients to evaluate breast lumps, breast pain, and other concerns. Dr. Harrigal is a passionate advocate for breast cancer screening, emphasizing the recommendation that women begin annual mammograms at age 40. Dr. Harrigal, please take it away.
Kristen, thank you so much for inviting me, and thank you guys so much for attending this webinar and for letting me share some information with you guys today. And Kristen, can you hear me okay?
Maybe just a little bit louder.
Okay, I will talk a little louder. Is that better? Okay. So we have a lot of slides to get through, and so I'm going to be speaking pretty quickly and not just through all the content. Disclosures, I have no financial disclosures. I am a salaried employee like a teacher. Specifically, I make no extra money if more women get mammograms. So we're going to start with some background information. First of all, what is a screening test? A screening test is a test that looks for a disease such as breast cancer in women without any symptoms. These are asymptomatic, healthy women. Why are screening tests important? So screening tests are important because
Dr. Harrigal, we're losing a little bit of audio for you.
Oh no. No? Better or worse? Okay, I'll hold it closer to my face. So screening tests find cancer sooner before they become larger and symptomatic. And cancers that are detected earlier are often more treatable than cancers that are found later. Cancers that are found earlier are early stage and they have less morbidity and mortality. So cancers that are found earlier are smaller and they usually require less chemotherapy, less radiation therapy, and smaller surgeries. So why do we screen for breast cancer? Because breast cancer is a big deal. Breast cancer is the most common cancer in women worldwide, and it is the second leading cause of cancer death in U.S. women, second only to lung cancer, which is a leading cause of cancer death. So last year, more than 250,000 women were diagnosed with breast cancer, and over 40,000 women died of breast cancer last year. I know that we think of breast cancer as easily treatable, but lots and lots of women die every year of breast cancer. More than 40,000 women in the U.S. died of breast cancer last year. So in 2012, deaths from breast cancer account for an average of about 19 years of life lost due to breast cancer. So if a woman dies of breast cancer, on average, she would have had about 19 more years of life to live. So some statistics: 1 in 8 women will be diagnosed with breast cancer. 1 in 6 breast cancers occur in women in their 40s. 3/4 of women diagnosed with breast cancer have no family history, and they are not considered high risk. So we're going to talk about mammograms. What is a mammogram? So a mammogram is a very safe, low-dose X-ray picture of the breast. Mammography has been widely available since the 1980s. Here's a boot camp to mammography. So this is a one-view mammogram picture. It's a side view picture of the breast. And this is what a normal mammogram looks like. So on the left, we have a normal mammogram, and on the right, we have a mammogram showing a breast cancer. So breast cancer is right on the mammogram, and we'll talk about more about that later. But this is what we're looking for when we're reading mammograms. So on the left, we have a large breast cancer. This woman came in with a lump. And on the right, we have a small breast cancer, one that was found by screening way before it was a lump that this woman could feel. So this woman is more likely to die of breast cancer because her breast cancer presented larger and later. And this woman is more likely to live and survive this breast cancer. And this woman is going to require less treatment than this woman in general. So mammography is the only screening tool shown to decrease mortality from breast cancer. There's no other tool that's been shown to decrease mortality. Not 3D mammogram, not ultrasound, not MRI. This is the only tool that's been shown to directly decrease deaths from breast cancer. So mammography saves lives, and this has been supported by decades of research and dozens of research trials in multiple countries. And the decrease in mortality is usually around 30%. So how does mammography do this? So mammography does this because screening breast cancers, like we said, they catch cancers before they become lumps that a woman or her clinician can feel. And this is important because the size of the breast cancer at the time of diagnosis is directly related to mortality. The larger a breast cancer is at the time of diagnosis, the more likely the woman is going to die from that breast cancer. So the whole point of mammograms is to catch breast cancer sooner when they're smaller to save more lives. So this is a busy chart, and let me get my little pointer tool. So this is showing the distribution and size of breast cancers as a function of time. So mammography started in the early 80s, and before that time, most of the breast cancers diagnosed were large, and this is depicted in red. And the minority of breast cancers are small, depicted in blue. Mammography started here, and once mammography started, we were able to catch smaller breast cancers sooner. So today, if you look at today's breast cancer and how big they are at the time of diagnosis, most of them are smaller, and only a very small minority of them are large. And this is directly related to mammography. So this is another way to look at this information. Mammography became available during this yellow time span, and before that time, most of the breast cancers were larger, in this size depicted in red, and only a few of them were small. And as time goes on, and currently we're detecting more smaller breast cancers, including BCIS, and the number of large breast cancers has overall decreased, and this is as a result of screening mammography. So there have been many research trials that have shown this benefit in mortality reduction from breast cancer. The largest of which was a randomized controlled trial that was done in Sweden. And we have 30 years of follow-up data from this trial. So basically there were 2 counties in Sweden when mammography was introduced. And the counties are right next to each other. So in one county, the women were invited to screening mammography. And in the second county, right next door, the women were not invited to screening mammography. So when we look at the mortality from breast cancer in these 2 counties that are right next to each other, there was a 30% decrease in mortality from breast cancer in women who were screened. So here's a way to show this. On the left, we have the mortality from breast cancer, and in the right, or in the bottom column, we have 30 years of follow-up data. And this is, like we said, the mortality reduction is about 30%. So there's about a 30% lower mortality in women who are screened as opposed to women who are not screened. So there are multiple issues for screening mammography, the biggest of which are when to start, what age to start, and do you screen yearly or every other year. Those would be the main ones that we focus on. So first of all, when do we start screening? And the answer is most women should start screening at age 40. Why do we start at age 40? Because breast cancer is a big deal for women in their 40s. 1/3 of all years of life lost due to breast cancer is from women who are diagnosed in their 40s. Breast cancer is a big deal for women in their 40s. We all know women who are diagnosed in their 40s. So this is a busy slide showing 3 different sets of data. So the first is the distribution of breast cancer cases as a function of age. The middle one is the distribution of breast cancer deaths as a function of age. And this is the number of years of life lost due to breast cancer as a function of age. And as you can see, nothing magical happens at age 50. Women in their 40s get breast cancer. And the next slide was focusing on the chart C on the right. So this is years of life lost due to breast cancer. And for women who are diagnosed in their 40s, these are women who lose the most years of life because if they're going to die, they're going to have all this, they should have had all this potential to live to age 85 or greater. So 1/3 of all years of life lost due to breast cancer is from women who are diagnosed in their 40s. So why do we recommend starting at 40? Because it saves the most lives and it saves the most years of life. This is another busy slide, but it's an important one showing that the highest mortality reduction, so this is the function on the left, and this shows the number of screening mammograms. And the largest mortality reduction in breast cancer starts if you screen annually at 40. This is if you start every other year at 50. So this screening in this yearly at 40 saves more lives. It has a higher mortality in breast cancer reduction as opposed to starting every other year at 50. So what about screening yearly or every other year? And the answer is screening annually. Why? Because annual screening saves the most lives and the most years of life. This is the same slide that we looked at before. This is mortality reduction from breast cancer as the function of mammograms. So screening annually at 40, and this is every other year at 40. And if you screen annually at 40, you have the highest mortality reduction from breast cancer as opposed to starting every other year at 40. So screening at 40 saves the most lives, the most years of life, and annual screening saves more lives than screening every other year. Let me get rid of my little pointer tool for a minute. Okay, there. So isn't this controversial? No, this is not controversial. So all of this is supported by decades of research and dozens of research trials. Annual screening at 40 saves the most lives, the most years of life from breast cancer. So there's no society or task force that disagrees with this. These are facts supported by science. Differences in screening recommendations are due to the differences in the perceived risks versus benefits of mammogram. So let's take a look at the different screening recommendations that are out there. Pick a guideline, any guideline. And this is why there's a lot of confusion about when to start, yearly, every other year. So there are lots of different recommendations. And I apologize, this is for average risk women. This is not high risk women. This is not women who've been previously diagnosed or have significant family history. This is an average risk women. Here are 4 major examples of different guidelines that are out there. The first is American College of GYNs. Another one is U.S. Preventative Task Force. Another is the American Cancer Society. And then the NCCN guidelines. These are the experts in cancer treatment and diagnosis and screening. So all of these societies differ in whether or not to recommend a clinical breast exam. They differ in when to start mammograms. They differ in screening yearly or every other year. And they differ in when to stop. So the reason why there's a lot of confusion out there is because there's a lot of confusion in our own society guidelines. And we're going to focus in on these a little more here in a second. Let me get rid of the pointer tool. So this is the American Cancer Society guidelines. This is directly from their website. So let's focus in on their recommendations. So it used to be, prior to 2009, that they recommended once a year, every year, starting at 40. But that sort of changed in 2009 once the U.S. Preventative Task Force guidelines came out. And we'll talk more about that in a second. So American Cancer Society says women ages 40 to 44 should have the choice to start annual mammograms if they wish to do so. Women ages 45 to 54 should get mammograms every year. And women ages 55 and older should switch to mammograms every other year, or they can continue yearly screening. So this is also pretty confusing, rather than once a year, every year, starting at 40. They said, as far as when to stop, that screening should continue as long as a woman is going to be in good health for 10 years, that women should know the benefits, limitations, and harms linked to mammograms, and women should know how the breasts normally look and feel and report any change to their healthcare provider. This talks about women who are high risk. So some women, because of their family history or genetic tendency, should be screened with MRIs in addition to mammograms. And like they said here, the number of women who fall into this category is very small. And to talk to their healthcare provider. So that was the American Cancer Society. Next, we're going to look at National Comprehensive Cancer Network. This is NCCN. These are experts in cancer treatment, detection. They form national guidelines that we all follow. This is a busy slide, but basically in women who are asymptomatic of average risk over at age 40, annual screening mammograms to consider tomosynthesis, which is a 3D mammogram, and breast awareness and clinical encounter. And these are women who are at average risk. So Society of Breast Imaging, American College of Radiology, this is a society radiologists belong to, yearly starting at 40, similar to NCCN guidelines. American College of GYNs, women who are average risk should be offered screening mammography starting at age 40. They go on to say that this discussion should include information about the potential benefits and harms, but women should be offered it starting at 40. So the one that we will focus on, which is slightly controversial, is U.S. Preventative Task Force. So the U.S. Preventative Task Force in 2009 came out with new society guidelines, and this was a change from their 2002 guidelines. Prior to 2009, once a year, every year at 40 was generally the accepted model for average risk women. But in 2009, they came out with new recommendations, and there was definitely a change in opinions, and there was an emphasis on the risks and harms of mammogram, such as anxiety and this idea of overdiagnosis of breast cancer, which is a hypothetical notion that diagnosing too many breast cancers, that these don't kill women, and a array of other things. So this is from the U.S. Preventative Task Force guidelines, and I would say that they don't recommend against starting at 40. They found that they gave it a recommendation C class. They recommended Class B with a biennial screening every other year starting at 50, and then every other, and that, okay, so a Class C recommendation means that they can't strongly recommend it, and basically that there was not enough evidence to support recommending it with a Class B recommendation. They focused on things like false positive biopsy results, and they did say that for women who are at average risk, most of the benefits are every other year starting at 50, but they placed a higher emphasis on anxiety. So this is also from their website and from Annals of Internal Medicine discussing the U.S. Preventative Task Force guidelines. So they said that the decision to start screening before age 50 should be an individual one, and those women who place a higher value on the potential benefits could choose to start screening before the age of 50. This is also from the same paper. The false positive results are common, and they lead to unnecessary and sometimes invasive follow-up tests with the potential for psychological harms such as anxiety. So this was the first real emphasis on anxiety and false positive mammograms, and the need for extra pictures and the need for benign biopsies causes psychological harms such as anxiety. So looking at the Preventative Task Force, 16 volunteer members, they serve a 4-year term. They have experience in behavioral health, family medicine, geriatrics, internal medicine, pediatrics, OBGYN, nursing, health systems, health management and policy, and epidemiology. So a criticism of the U.S. Preventative Task Force in changing these guidelines is that in this group of people, there's not a single expert in breast cancer, not a single medical oncologist, radiation oncologist, breast surgeon, radiologist, or pathologist was involved in making these new society guidelines and changing the recommendation from every other year to, or every year at 40 to every other year starting at 50. And this was really a value judgment rather than a judgment based on scientific evidence. So that's the major criticism of these new U.S. Preventative Task Force guidelines that have been out since 2009. So this is from the U.S. Preventative Task Force website. They do not disagree with any of the facts that we've talked about. This is from their website. Annual starting at 40 saves more lives in most years of life as opposed to starting at 50. Annual screening, so annual screening starting at 50 as opposed to every other year starting at 50. So annual screening saves more lives and years of life. They do not disagree with those facts. So the disagreement is the risks and benefits and this idea of anxiety causing psychological harm and overdiagnosis of breast cancer. This is from their same website. From the same paper. This is the same slide that we saw before, reduction in mortality from breast cancer. Annual at 40 saves more lives than every other year starting at 50. So this is from their data. And as you can see, this is the same as the slide that we looked at before. Annual every year starting at 40 saves more lives, the higher mortality breast cancer reduction as opposed to every other year at 50. So are you guys confused? Don't be confused. So once a year, every year starting at 40 saves the most lives, and every other year at 50 saves the most mammograms. So we've discussed starting at 40 saves the most lives, the most years of life, and annual screening saves more lives than every other year. Another way to say this is screening once a year, every year starting at 40 saves the most lives from breast cancer. So that's a lot of background information. Next, we're going to follow up on how to read a screening mammogram report. So reading a screening mammogram report, it's pretty binary. It's either normal or it's abnormal. A normal mammogram, we either describe negative findings or we can describe some benign findings, and those women go back to yearly screening mammograms. So if it's normal, back to yearly screening mammograms. If it's abnormal, that's a BI-RADS 0, incomplete, additional pictures needed, then those women come in for additional workup. And for most women, that's just extra pictures with mammogram and ultrasound. A few of those women will undergo biopsies, but most of the women who have an abnormal mammogram, they get extra pictures and then they get released back into the wild. So the other important component of a mammogram report is breast density. So you get normal or abnormal, and then you'll get a description of the breast density. We're going to talk more about breast density on our talk next month, but it's important to discuss here just in how to read a mammogram report. So what is dense breast tissue? Dense breast tissue is very common. It is normal. It is not a disease. Normal breast tissue is white on the mammogram, and fat is black on the mammogram. So here are the 4 types of breast density. This is fatty, so this is less than 25% white breast tissue. It's mostly fat, which is dark on the mammogram, so dark gray or black. The next is scattered, so a little bit more than 25% of white breast tissue. The next is heterogeneously dense, so more than 50% white breast tissue on the mammogram. And then extremely dense, greater than 75% white breast tissue on the mammogram. So in general, there's 2 categories. So this category, these 2 categories are not dense, and these 2 categories are dense. So as we said before, dense breast tissue is very common. 50% of women have dense breast tissue. 50% of women walking around have dense breast tissue. It is not a disease. It is common and normal. But why do we make a fuss about it? And the reason is because 2 reasons. Number 1, cancers can hide more easily on a mammogram for women with dense breast tissue, and there is an increased risk of breast cancer in women who have dense breast tissue. So cancers hide more easily, and there's an increased risk of breast cancer. Like we said before, normal breast tissue is white on a mammogram, and breast cancer is also white on the mammogram. So on the left, we have a normal fatty breast, and on the right, we have a cancer in a fatty breast. It is really easy to see breast cancer in a fatty breast. It is the only thing that's white on the mammogram. So this is on the left, we have a normal, extremely dense breast tissue, and on the right, we have a cancer in an extremely dense breast tissue. And as you can see, the breast cancer is almost invisible in the woman who has extremely dense breast tissue. It's like looking for a snowball in a snowstorm. It's nearly impossible to find. So for those women, this is why we discuss supplemental screening with ultrasound or 3D mammogram. So on the left, really easy cancer to see in a fatty breast, and on the right, an invisible cancer in an extremely dense breast. That's why we make a fuss about breast density. So what do? We notify women, we notify their physicians and their clinicians of their breast density, and we can consider supplemental screening, and we're going to talk more about that next month. So we've talked about dense breast tissue, and we've talked about average risk women and the screening recommendations. What about high-risk patients? So we've looked at this slide before. This is the NCCN guidelines in asymptomatic average risk women over 40. But let's look at asymptomatic women with an increased risk of breast cancer. So these are the different high-risk categories. So women who have previously had breast cancer, women who have a lifetime risk greater than 20% based on risk models, women who have received radiation therapy, typically this is for lymphoma, women who are high risk, and women who have had atypia based on prior biopsies, and women who have a genetic predisposition based on family history. Those women should be referred to a genetic counselor, and we'll talk about that in a second. So we've talked about the 5 major camps. This is just a closer look at these 3 of the 5. The next slide describes the other. This is women who are at an increased risk, and the NCCN has guidelines for these women who are at high risk. So this includes women who have a prior history of breast cancer. These women are high risk. The breasts are usually mirror images, and these women are likely to develop, or some of these women can develop recurrences in the same breast or in the other breast as time goes on. So it's important that these women still get yearly screening. The biggest category that clinicians see in the general public is the second category, women who have a lifetime risk greater than 20% based on risk models that are typically derived on family history. So we'll talk about this risk model in a second. So if women have a greater than 20% lifetime risk, in addition to yearly screening mammogram, in addition to a referral to a genetic counselor, they consider screening tomosynthesis, which is the 3D mammogram. And the big recommendation here, which is different than average risk women, is annual breast MRI. We'll talk about that more in a second. But basically, MRI is has the highest cancer detection rate. In women who have greater than 20% lifetime risk, surveillance yearly breast MRI is recommended in addition to the mammogram. Other populations of women we've talked about women who've had radiation therapy, especially if they were in their teens or early 20s. These women are at increased risk of developing breast cancers as a result of the high-dose radiation that they got to their chest from treatment for lymphoma. And the other 2 camps that we looked at are other high-risk women and other high-risk women who have a history of atypia based on prior benign breast biopsies. And in general, consider MRI in addition to yearly screening mammogram. So we talked about different risk models that can calculate a woman's lifetime risk, and to prove that her lifetime risk is greater than 20%, which is the tip-off point at which time we recommend an annual breast MRI in addition to screening mammogram. The Gale model is one of the most popular risk models used. The Gale model is online. There are other risk models. One of the most popular is called Tyrer-Cruzik, and there are other risk models, but this one is pretty popular. It factors in things like age at menarche, age, number of births, number of relatives with breast cancer, the number of prior biopsies, and the race of the patient to calculate the risk. And if a woman is greater than 20% lifetime risk, surveillance breast MRI is recommended. So another topic we wanted to cover is when to recommend genetic counseling. Again, from the NCCN guidelines, because these people are the experts, this is a very busy slide, but I wanted you guys to have this. There are many reasons to recommend genetic risk evaluation and to recommend counseling and genetic testing. Here are some of the most popular. Basically, you can get there many different ways. If a woman has ovarian cancer, if a woman has breast cancer, such as any woman who's diagnosed with breast cancer before age 50, any woman with triple-negative breast cancer before age 60, and other ways that will get you there are close family members. Any family that has a male breast cancer in their family, that's a tip-off to get genetic counseling. Any combination of family members with these other types of cancer, or if a person does not have breast cancer but they have close relatives meeting the following criteria, that is a reason to get referral to genetic counseling. Again, it's a busy slide, but a lot of people meet these criteria. This is recommendation for genetic counseling for the BRCA1 or 2 gene. As you know, this is the Angelina Jolie effect. These women who have the BRCA genetic 1 or 2 genetic mutation are at very, very high risk of developing breast and or ovarian cancer. And these are recommendations for genetic testing for the BRCA1 or 2 genetic mutation. So we're going to change gears for a second and talk about breast MRI. We've talked that women who are high risk, especially those 5 different camps of patients, in addition to yearly mammograms, should also get yearly breast MRI. So here's a picture from a breast MRI. This is from the same patient that we looked at before who had the breast cancer by mammography. So MRI uses contrast dye to get these pictures. So the benefits of breast MRI is that it's by far and away the most sensitive and powerful breast imaging tool that there is. It's more sensitive than ultrasound. It's more sensitive than 3D mammogram. It's more sensitive than regular mammograms. It has by far and away the highest cancer detection rate because we're injecting contrast dye and we're getting kinetics and enhancement information rather than just anatomy. The risks is that it has a higher false positive rate. This higher cancer detection rate comes with a higher false positive rate. We're more likely to find things that are normal, that light up, that can lead to biopsies that are benign. But by far and away, it has the highest cancer detection rate, but with that comes a higher false positive rate for benign findings. Breast MRI is costly. It's expensive. There's a question of gadolinium deposition. For people who receive multiple doses of this contrast, it has been found to be deposited in their brains, but there is no known consequence for this, but it's something that's being discussed as an associated risk or side effect, if you will. So breast MRI is not for your average risk patient. It is for high-risk patients who have greater than 20% lifetime risk of breast cancer. Typically, these are genetic mutation carriers, such as the BRCA genetic mutation, but there are other mutation carriers. And these are women who also meet high risk based on other risk models. So this is NCCN guidelines of who should be getting breast MRI in addition to mammography. Typically, like we said, BRCA genetic mutation carriers, first-degree relatives of a BRCA carrier, but they're untested, women who have a lifetime risk greater than 20%, and most of who falls into this category, they are women who are, let me get my pointer out, they are, let's see, there we go. It is this group here, this lifetime risk greater than 20% based on risk models that include things like family history and other prior atypia on biopsies. So this is true in our practice and in many community practices. You know, despite the fact that we recommend surveillance breast MRI in women who are high risk, women are just not getting their breast MRRs. They're barely getting their mammograms, let alone breast MRRs. So this was one research paper showing that the utilization of screening MRs is not consistent with society guidelines. Women who are high risk are just not getting breast MRs. There's many barriers such as insurance coverage and access because of cost, and the numbers just are not there. So that's most of what we're going to talk about. We're going to spend a few minutes talking about in a perfect world and what we see more commonly in practice and our goals moving forward. So in a perfect world, women would get annual mammograms beginning age 40. Women would know their breast density. Women with dense breast tissue would know that they have dense breast tissue, and they would be able to get supplemental screening if they choose to do so. Women with greater than 20% lifetime risk would get breast MRIs. In the real world, so when about a year and a half ago, I was new to the department, and I was looking at goals for 2017, just to focus in on what we can improve on. So back in 2016, we looked at the last 10 women who were diagnosed with breast cancer at our facility. We just looked at the 10 consecutive most recent breast cancer diagnosis. So the question was, when was their last mammogram? One second, I'm having difficulties moving forward. 1 second, my computer's being slow. So when was their last mammogram? 1 second. Kristen, are you able to advance the slide from your end?
Yeah, you should be on the right slide now.
Okay, I think it's my computer that's being slow. I apologize, guys. 1 second. Okay, there we go. So we looked at the last 10 women who were diagnosed with breast cancer, when was their last mammogram? So only 1 out of 10 women had had a mammogram within the past year. And she was the only woman who was diagnosed with the lowest grade of breast cancer, DCIS. All of these other women, 9 out of 10 women had not had a mammogram within the past year. So then we said, okay, so what if you follow U.S. Preventative Task Force guidelines? So only 3 out of 10 women had had a mammogram within 2 years. So in summary, only 1 out of 10 women had had a mammogram in the past year. 3 out of 10 women had had a mammogram in the past 2 years. And this is what we see consistently. Every day this is what we see. More likely, we have women who are diagnosed with very big breast cancers that are palpable, that are at advanced stage, who have not had a mammogram, not only within the past year. Some of these women, like this woman in particular, she had a family history of breast cancer, and she'd never had a mammogram. This woman never had a mammogram. Her mom died of breast cancer. So this is more commonly what we're seeing. We're not seeing small breast cancers. We're seeing large breast cancers that are diagnosed at advanced stage. And remember, the woman on the left with the larger breast cancer that's palpable is more likely to die of her breast cancer than the woman with a tiny breast cancer that no one can feel, that's found on a screening mammogram that's early stage. So in a perfect world, there'd be no racial or economic health disparities. But in the real world, so this was the latest American Cancer Society statistics that were just released in 2017. They do every other year statistics and talk about population risks and overall statistics for breast cancer. So the ACS statistics show that the decrease in breast cancer deaths is from 2 things. Number 1, better treatment. Number 2, earlier detection with mammography. So better treatment and earlier detection with mammography have resulted in about 300,000 women between 1990 and 2015, over 300,000 women had deaths avoided from breast cancer because of better treatment and earlier cancer detection. And this is published in New England Journal. The total decrease in mortality is around 39%. But not all women have benefited equally. There is an excess breast cancer deaths in Black women. So here is a slide showing the rate of breast cancer per 100,000. And this is the mortality rate per 100,000 and based on ethnicity. 1 second. So as you can see, the breast cancer mortality, mortality of breast cancer in Black women is higher than the mortality of breast cancer in white women. And these breast cancer death rates were 39% higher in Black women than in white women. This is in 2015. In 2015, the breast cancer death rates were 39% higher in Black women than in white women. And this is in every single state in the U.S. Breast cancer death rates are higher in Black women than in white women. And as the treatments are improving, the racial disparity is increasing. So, right, this is 2015 at the end of the slide where the arrow is. This disparity is increasing over time, the excess number of breast cancer deaths in Black women. So this is multifactorial. There's a lot of research going on how we can change this and stop this. Unfortunately, Black women have more aggressive breast cancers. They are more likely to have triple negative and inflammatory breast cancers than white women. They're more likely to present at a higher stage of diagnosis. There are many factors that affect this, including access to treatment, access to health insurance, access to mammography, and access to and enrollment in clinical trials. So how are we doing in Nevada? So in Nevada, Black women had an excess of breast cancer deaths about 20% higher than in white women. So they had 20% higher breast cancer death rates in Black women than in white women. This slide is busy, but I wanted you guys to have this information. This is showing the disparity in breast cancer mortality deaths. Breast cancer mortality in Black women as opposed to white women. This is the excess in breast cancer deaths ranked by states. And as you can see, Nevada, it was statistically significant. It was found to be dark blue. It had a relatively low disparity in breast cancer deaths in Black women as opposed to white women. And the reason why is a little unsettling. So the reason why, so this is mortality rates in women based on ethnicity. So basically it's a busy slide, but like I said, I wanted you guys to have this information. So Nevada had the highest mortality rate in white women out of any state. So the reason that our disparity back here is relatively low compared to other states, here we're relatively low, is because we had the highest mortality of white women out of any state in the United States. So our excess in breast cancer deaths was relatively small because we had the worst mortality in breast cancer deaths, or highest mortality of breast cancer in white women. So what about the use of mammography? How is Nevada doing? Again, a busy slide, but I wanted you guys to have this information state by state. This is the prevalence of mammography. So Nevada was slightly below national average for the use of mammograms in all women. But what about Black women in Nevada? So Black women in Nevada had the lowest use of screening of mammography out of any state in the U.S. So we've talked before that once a year, every year, starting at age 40, saves the most lives from breast cancer. And moving forward, these are goals that we need to have as a state moving forward to improve healthcare in our own community. We need to increase the utilization of screening mammograms. We need to decrease breast cancer deaths in all women. We need to increase the use of supplemental screening for women who have dense breast tissue. We'll talk more about that next time. We need to increase the number of breast MRIs for women who are at high risk, these women who are greater than 20% lifetime risk. We also really need to focus on decreasing racial health disparities and focusing on decreasing these health disparities and economic health disparities. So I want to you guys to remember that mammography saves lives, and I want to thank you for your time.